Today, we're going to discuss another tool in rehabilitation, biofeedback. One of the things I enjoy about biofeedback is that it allows us to make something invisible visible. We often ask patients to activate a muscle, improve posture, or change a movement pattern, but they can't actually see what they're doing. Biofeedback provides immediate information about their performance, allowing them to learn movement more efficiently. As you'll see throughout today's lecture, biofeedback isn't a treatment by itself, it's a teaching tool. Like any teaching tool, its effectiveness depends on how we use it. During today's lab, you'll have the opportunity to work with 3 different types of biofeedback: pressure biofeedback, surface EMG biofeedback, and a laser pointer for movement retraining. Before we dive into the science, I'm curious about your own experiences. Has anyone ever used biofeedback before? Maybe you've seen EMG during an undergraduate kinesiology lab. Perhaps you've used a blood pressure cuff during exercise instruction. Or maybe you've seen a physical therapist use ultrasound imaging to teach muscle activation. Even if you haven't used these tools personally, you've probably experienced biofeedback in everyday life. A smartwatch that tells you your heart rate is biofeedback. A mirror while lifting weights is visual biofeedback. Your car beeping as you back up is another form of feedback designed to change behavior. The Guide to Physical Therapist Practice defines biofeedback as a training technique that allows an individual to gain voluntary control over muscular or autonomic nervous system functions by providing external information through visual or auditory signals. I want you to pay attention to 2 words in this definition: training technique. Biofeedback doesn't strengthen muscles by itself. It doesn't heal tissue. It doesn't reduce pain directly. Instead, it helps patients learn. That's why we'll spend so much time today discussing motor learning. The biofeedback device simply gives the nervous system better information during practice. Another simple way to think about biofeedback is this: we monitor something the body is already doing automatically, and then present that information in a way the patient can consciously understand. Depending on the device, that information might represent joint position, muscle activation, force production, pressure, balance, center of mass. The patient then uses that information to improve movement. Think about learning to shoot a basketball. Without feedback, you simply guess whether you're improving. If someone tells you your elbow is drifting outward, suddenly you know what to change. Biofeedback provides that same type of information for movement rehabilitation. There are many different forms of biofeedback, and it's important to recognize that they each measure different variables. Force plates measure force and weight distribution. Pressure biofeedback measures changes in pressure usually caused by body movement. Rehabilitative ultrasound imaging allows us to visualize muscle contraction in real time. Visual biofeedback may involve mirrors, cameras, or laser pointers. EMG biofeedback measures the electrical activity associated with muscle activation. Throughout today's lab, we'll primarily use pressure biofeedback, surface EMG, and laser feedback because they are practical, relatively inexpensive, and commonly available in outpatient orthopedic practice. One of the simplest forms of biofeedback is something that almost everyone has at home: a bathroom scale. Imagine a patient who has undergone a total knee replacement and has been instructed to put only 50% of their body weight through the surgical leg. Most patients have no idea what 50% actually feels like. If I simply tell them to put a little weight on it, they're forced to guess. Now, if we have them stand on a bathroom scale, the scale provides immediate visual feedback. The patient can see exactly how much weight they're placing through that limb and adjust until they reach the desired amount. In this case, the scale isn't treating the patient, it's teaching them. Once they repeatedly experience what the correct amount of weight bearing feels like, they begin to develop an internal sense of that movement and eventually no longer need the scale. This highlights an important principle that we'll return to throughout today's lecture. Biofeedback is most valuable early in the learning process. As the patient develops better body awareness, we gradually reduce the amount of feedback so they become less dependent on the device and more reliant on their own sensory system. Let me ask you a question. If I leave the patient standing on the scale for every exercise session over the next 6 weeks, do you think they'll become better at estimating weight bearing without the scale? Probably not. They may become excellent at reading the scale, but not necessarily at sensing the correct amount of weight on their own. That's why, as physical therapists, our goal isn't to create dependence on biofeedback. Our goal is to use it as a temporary teaching tool and then gradually remove it as learning occurs. This image shows an athlete performing a cutting maneuver while landing on a force plate. At first glance, you might think the force plate is simply measuring how much force the athlete is producing, but it actually provides much richer information than that. The force plate measures the ground reaction force generated as the athlete pushes into the ground. The arrow that you see represents that force vector. It shows both the magnitude and the direction of the force being transmitted through the lower extremity. Now notice how that vector relates to the position of the ankle, knee, and hip. As physical therapists, we're interested in whether the joints are aligned to efficiently absorb and transmit those forces. For example, if the athlete demonstrates excessive dynamic knee valgus during a cutting maneuver, the force vector may pass farther away from the knee joint center. That increases the external moment acting on the knee and often requires greater muscular demand to maintain control. Over time, these altered mechanics may contribute to injury risk or decreased performance. This is where biofeedback becomes so valuable. Rather than simply telling an athlete, keep your knee from collapsing inward, we can provide objective information about how their movement changes the forces acting through the limb. They can immediately see whether changes in their technique produce a more favorable movement pattern. Force plates are commonly used in return to sport testing after injuries such as ACL reconstruction. They help us identify asymmetries in loading, rate of force development, braking forces, propulsion, and movement strategy that may not be visible to the naked eye. The important point is that biofeedback allows us to quantify movement instead of relying solely on observation. Our eyes are very good, but technology can detect subtle differences that we simply can't appreciate in real time. Here we have an athlete performing a Romanian deadlift while standing on two independent force plates, one beneath each foot. Although this looks like a simple strengthening exercise, the force plates are providing us with a tremendous amount of information that we couldn't accurately obtain just by watching. As the athlete performs the movement, each force plate continuously measures how much force is being placed through each lower extremity. The software then displays that information in real time, allowing both the clinician and the athlete to see whether the load is being distributed evenly between the right and left legs. This is particularly valuable because our visual observation isn't always accurate. An athlete may appear perfectly symmetrical, yet the force plates reveal that they're placing 60 or even 70% of their body weight on one limb while unloading the other. That becomes especially important following injuries such as an ACL reconstruction, total hip arthroplasty, stress fracture, or any condition where patients unconsciously protect the involved side. Many patients genuinely believe they're loading both legs equally, but objective biofeedback often tells a different story. The real power of biofeedback is that the athlete doesn't have to wait until after the movement to receive feedback. They can immediately adjust their weight distribution while watching the display. If they notice they're shifting much onto the uninvolved side, they can consciously redistribute their weight and instantly see the numbers move towards symmetry. Over repeated practice, they begin to associate the sensation of balanced loading with the objective feedback from the force plates. Eventually, as their body awareness improves, we can remove the visual feedback and ask them to reproduce that same symmetrical movement without looking at the screen. That's the ultimate goal, not dependence on the technology, but improved internal awareness and movement control. Pressure biofeedback is probably one of the simplest and most useful forms of biofeedback you'll use as a physical therapist. The pressure cuff itself doesn't measure muscle activation. It measures changes in pressure caused by body movement. We commonly use it for deep cervical flexor training, lumbar stabilization, abdominal control, and pelvic positioning. During lab, you'll discover something important. A patient can successfully change the pressure while using the wrong muscles. So the pressure cuff tells us whether movement occurred, but it doesn't tell us which muscle produced it. That's why your observation as the clinician remains essential. Rehabilitative ultrasound imaging allows us to actually watch muscles contract in real time. This is particularly useful for deep muscles such as the transversus abdominis or lumbar multifidus, which are difficult to palpate. Unlike diagnostic ultrasound, we're not looking for pathology. Instead, we're using the image as a teaching tool. Visual biofeedback can be remarkably effective because humans learn well through vision. One of the simplest, least expensive, and most commonly used forms of biofeedback is a mirror. At first glance, a mirror may not seem like technology, but it provides exactly the same function as many of the devices we've discussed today. It gives the patient immediate information about their movement that they otherwise couldn't accurately perceive. Think about a patient performing a squat. They may feel as though they're keeping both knees aligned, but when they look in the mirror, they immediately notice one knee collapsing into dynamic valgus. That visual information allows them to make corrections in real time. The same principle applies to posture training. A patient with forward head posture often has no idea what their posture actually looks like. When they stand in front of a mirror, they can compare what they feel with what they see and begin developing a more accurate sense of body position. We also use mirrors during gait training, balance activities, single leg exercises, shoulder rehabilitation, and even facial rehabilitation following neurological injury. In each case, the mirror provides augmented visual feedback that helps the patient improve movement quality. What's important to recognize is that the mirror isn't correcting the movement. The mirror is simply providing information. The patient's nervous system is using that information to modify the movement. That's exactly what biofeedback is designed to do. Like every other form of biofeedback we've discussed today, the mirror should be viewed as a temporary teaching tool. Early in rehabilitation, patients may need the mirror to recognize movement errors. As their proprioception and body awareness improve, we gradually remove the mirror so they learn to perform the movement using their own intrinsic feedback. In other words, our goal isn't for patients to become dependent on looking in a mirror every time they squat or walk. Our goal is for them to develop an internal sense of what good movement feels like, so they can reproduce it confidently in everyday life. Another example we'll use today is a laser mounted on the head. As the patient moves, the laser projects onto a target. This provides immediate information about head position and movement accuracy. It's particularly useful for cervical proprioception, posture retraining, vestibular rehabilitation, and movement precision. One thing to notice is that this creates what we call an external focus of attention. Rather than thinking about individual neck muscles, the patient simply tries to keep the laser inside a target. Later in today's lecture, we'll discuss why external focus often produces superior motor learning. Now let's transition into one of the most common forms of biofeedback you'll encounter in orthopedic physical therapy: surface electromyographic, or EMG, biofeedback. Surface EMG uses electrodes placed on the skin to detect the electrical activity produced when muscle fibers depolarize. That electrical activity is then converted into a visual display, a sound, or both, giving the patient immediate feedback about whether a muscle is active. Notice what I did not say. I didn't say it measures muscle strength. EMG does not tell us how much force a muscle is producing. Instead, it tells us that electrical activity is occurring. In other words, it's measuring activation, not strength. This distinction is incredibly important because patients often assume that a higher EMG reading means they're stronger. In reality, many factors influence the signal, including electrode placement, skin impedance, adipose tissue, and the settings on the device. During today's lab, you'll place electrodes on one another and immediately see how muscle activity changes during different movements. One of the most common misconceptions students have is confusing neuromuscular electrical stimulation, or NMES, with EMG biofeedback. Although both involve electrodes placed on the skin, they do almost opposite things. With NMES, the machine is sending electricity into the patient to produce a muscle contraction. The patient can remain completely passive while the machine generates the contraction. With EMG biofeedback, the opposite occurs. The patient generates the electrical signal through their own muscle contraction, and the machine simply records and displays that activity. No electrical stimulation is being delivered into the body. Think of it this way: NMES is output, EMG biofeedback is input. One creates muscle activity, the other measures muscle activity. As physical therapists, we often combine the two in rehabilitation, but it's important to understand that they serve very different purposes. There are several different ways to measure muscle activity, and each has different clinical applications. Surface EMG is what we'll use in today's lab. Electrodes are placed on the skin to record the combined electrical activity of many muscle fibers beneath the electrode. It's completely non-invasive and is commonly used in orthopedic rehabilitation, sports medicine, ergonomics, and motor retraining. High-density surface EMG uses many closely spaced electrodes to create a much more detailed map of muscle activation. Researchers often use this technology to study motor unit recruitment patterns and regional muscle activity. Needle EMG is very different. A fine needle electrode is inserted directly into the muscle to record individual motor unit action potentials. This provides much greater specificity but is invasive and is typically performed during electrodiagnostic examinations rather than routine physical therapy treatment. For the vast majority of outpatient orthopedic applications, surface EMG is the most practical and clinically useful form. Biofeedback can serve many different purposes depending on the patient's impairment. Sometimes we're trying to recruit a muscle that isn't activating well, such as the quadriceps after ACL reconstruction. Other times we're trying to inhibit excessive muscle activity, such as reducing upper trapezius overactivity during shoulder rehabilitation. We can use biofeedback to improve coordination between muscles, helping agonists and antagonists work together more efficiently. It can improve neuromuscular control, movement quality, joint stability, posture, and functional performance. In some cases, improving movement quality can even contribute to pain reduction because the patient begins using more efficient movement strategies. The important point is that biofeedback doesn't have one indication. It can be adapted to many different clinical goals. Before we discuss how these devices work, I want to emphasize what I think is the single most important point of today's lecture. Biofeedback should always be viewed through the lens of motor learning. The device itself doesn't improve movement. Learning improves movement. Biofeedback simply provides information that helps the nervous system solve a movement problem more efficiently. Every time you use biofeedback clinically, ask yourself these questions. What am I trying to teach? What information does the patient need? How long should I provide feedback? And perhaps most importantly, when should I begin removing the feedback so the patient becomes independent? If you remember nothing else from today's lecture, remember that biofeedback is a teaching tool, not a treatment. Let's take a closer look at what the machine is actually detecting. Every time a motor neuron activates a muscle fiber, that muscle fiber depolarizes, producing an electrical signal known as a muscle action potential. The surface electrodes detect thousands of these electrical events occurring beneath the skin and combine them into a measurable signal. Notice that EMG tells us when electrical activity is occurring, but it doesn't directly measure force production. Two contractions that produce similar force may have different EMG amplitudes, and two people generating identical force may produce very different EMG signals. The visual display or audible tone simply represents the amount of electrical activity being detected. Every year, this slide creates confusion, so let's spend a minute clarifying it. Our biofeedback units are labeled in a way that's a little counterintuitive. On these devices, a lower gain setting actually makes the unit more sensitive. In other words, the machine can detect very small amounts of muscle activity. As you increase the gain value, the device becomes less sensitive and requires a larger electrical signal before it registers activity. Think of it like turning up the threshold rather than turning up the volume. During lab, if your unit doesn't seem to be detecting muscle contractions, one of the first things you should check is the gain setting before assuming the electrodes are misplaced. Now let's briefly examine what happens inside the machine. Every EMG system contains four major components. First is the signal source, the muscle itself. Next comes the transducer or electrode, which detects the electrical activity. The amplifier then increases the tiny electrical signal while reducing background noise. Finally, the signal processing circuitry converts that information into something meaningful, such as a graph, a number, a light, or an audible tone. You don't need to become biomedical engineers, but understanding this sequence helps explain why electrode placement and signal quality matter so much. The muscle itself is the signal source. Several factors influence how much electrical activity the electrodes detect. The closer the electrode is to the active muscle fibers, the stronger the signal. The size of the electrical depolarization also affects the recorded signal. In addition, skin, fat, and other tissues between the muscle and the electrode can reduce signal quality. This explains why two patients performing the exact same exercise may produce different EMG amplitudes. It's another reminder that EMG values should be interpreted cautiously and are often most useful for comparing changes within the same patient over time rather than comparing one patient to another. Now let's look a little more closely at what happens after the electrode detects the electrical signal. The electrodes convert the tiny electrical currents generated by muscle fibers into signals that the biofeedback unit can interpret. These signals are incredibly small, measured in microvolts, so they must be amplified and processed before they become useful. Depending on the system, you may see a raw EMG waveform, a smoothed bar graph, numerical values, lights, or even hear an audible tone. While these displays look different, they're all providing the patient with the same basic information. Your muscle is active, or your muscle is relaxing. One important point to remember is that the display is designed for learning, not for making a medical diagnosis. We aren't trying to analyze every spike in the waveform. We're trying to give the patient simple, understandable feedback that helps improve movement. The amplifier is one of the unsung heroes of every EMG system. Remember that the electrical signals coming from skeletal muscle are extremely small. Without amplification, they would be impossible to detect accurately. The amplifier performs several important jobs. First, it increases the size of the signal so it can be displayed. Second, it reduces unwanted electrical noise from the environment. Third, it helps isolate the muscle signal from interference and minimizes distortion. Think of trying to listen to someone whisper in a crowded restaurant. The amplifier is essentially making the whisper louder while reducing the background conversations. As clinicians, we don't adjust most of these processes, but understanding that they occur helps explain why high quality equipment and proper setup are so important. This slide highlights some of the most common reasons EMG recordings can become inaccurate. First is crosstalk, which occurs when the electrodes detect electrical activity from neighboring muscles instead of only the target muscle. For example, if you're trying to monitor the gluteus medius, but the tensor fascia lata is highly active, both muscles may contribute to the signal. Second is proper skin preparation. Oils, sweat, lotions, hair, and dead skin all increase electrical resistance and reduce signal quality. That's why we typically clean the skin with alcohol and, when appropriate, shave excessive hair before applying electrodes. Third is electrode placement. For most surface EMG applications, electrodes are placed over the muscle belly where the greatest number of muscle fibers can be detected. During lab, you'll quickly realize that moving an electrode just a few centimeters can dramatically change the quality of the signal. Technology alone doesn't create better outcomes. The clinician still has to make good decisions. First, ask yourself whether the information you're providing is actually meaningful to the patient. If they don't understand what the feedback represents, it's unlikely to change their movement. Second, remember that biofeedback can be mentally fatiguing. Patients are processing visual information, auditory information, body awareness, and movement all at the same time. For some individuals, particularly early in rehabilitation, that's a significant cognitive load. Finally, think about how often you provide feedback. Too much feedback can create dependence, while too little may not provide enough information for learning. Finding that balance is one of the keys to becoming an effective clinician. Biofeedback has applications across many areas of physical therapy. One of the most common uses is pelvic floor rehabilitation, where surface EMG helps patients learn to activate or sometimes relax the pelvic floor muscles. In orthopedics, we frequently use biofeedback to improve muscle recruitment following injury or surgery, particularly when muscle inhibition limits normal movement. It can also be helpful in patients with temporomandibular disorders by teaching relaxation of excessively active jaw muscles. In neurological rehabilitation, biofeedback can improve motor control and movement coordination. Compared with many other interventions, surface EMG biofeedback has relatively few contraindications. We generally avoid placing electrodes over open wounds, active skin infections, or areas where adhesives cannot be safely applied. As always, patient comfort and skin integrity should guide our clinical decisions. Now let's begin looking at electrode placement. Here we're placing the electrodes over the quadriceps muscle group. Notice that the electrodes are positioned approximately halfway between the anterior superior iliac spine and the superior border of the patella. Why does placement matter? Because we want to maximize the signal coming from the target muscle while minimizing crosstalk from surrounding muscles. During today's lab, don't simply memorize where to place the electrodes. Instead, think about why that location produces the best signal. Good placement leads to meaningful biofeedback. Poor placement leads to misleading information. The lower trapezius is another muscle where careful placement is essential. Here, the electrode is positioned approximately 2/3 of the distance from the spine of the scapula toward the 8th thoracic vertebra. Clinically, this muscle is often retrained in patients with shoulder pain, scapular dyskinesis, or overhead athletes. One challenge is that the middle trapezius, upper trapezius, and surrounding muscles are all nearby. Accurate placement helps us isolate lower trapezius activity as much as possible. During lab, you'll notice that even slight changes in posture or shoulder position can dramatically influence the EMG signal. The gluteus medius is one of the most commonly retrained muscles in orthopedic practice. Here, the electrodes are positioned approximately halfway between the iliac crest and the greater trochanter over the muscle belly. One of the biggest challenges when assessing gluteus medius activation is minimizing activity from nearby muscles such as the tensor fascia lata. This is another example of why clinical observation remains important. The biofeedback unit tells us electrical activity is occurring, but it doesn't always tell us which muscle is contributing most to that signal. We still have to combine our anatomical knowledge, palpation skills, and movement analysis to correctly interpret what we're seeing. At this point, we're going to shift gears slightly. We've spent time discussing the technology, but now I want to focus on what we're actually trying to accomplish. Learning is defined as a relatively permanent change in performance that results from practice or experience. Notice the phrase relatively permanent. If a patient performs well only while looking at the EMG screen but immediately loses the skill when the device is removed, true learning hasn't occurred. Our goal isn't simply better performance during treatment. Our goal is lasting improvements that transfer into everyday activities after the feedback is gone. That's the difference between temporary performance and genuine motor learning. Motor learning doesn't occur all at once. It progresses through several stages. During the first stage, the cognitive stage, the patient is simply trying to understand what the movement is and how to perform it. Errors are common and they often benefit from frequent feedback. As practice continues, they enter the associative stage. Their movements become more consistent and they begin refining the skill. At this point, we often start reducing the amount of feedback we provide. Finally, they reach the autonomous stage. The movement becomes relatively automatic, requiring much less conscious attention. As clinicians, our job is to recognize which stage our patient is currently in, because that determines how much feedback we should provide. One of the biggest mistakes therapists make is continuing to provide constant feedback long after the patient no longer needs it. If we never remove the training wheels, patients never fully develop their own internal awareness of movement. Let's make these 3 stages a little more concrete by thinking about a skill that many of you have already begun learning, the side-lying lumbar gapping mobilization. Think back to the first time you attempted this technique in lab. During the cognitive stage, you probably weren't thinking about the patient's comfort or how much force to apply. Your brain was occupied with much more basic questions. Where do my feet go? Which hand contacts the pelvis? How do I stabilize the patient's shoulders? Am I standing on the correct side of the table? What direction am I supposed to move? At this stage, every part of the movement requires conscious attention. You're looking at the instructor, looking back at your lab manual, asking questions, making mistakes, and probably stopping halfway through to think about what comes next. That's completely normal. Performance is inconsistent because you're still building the motor program. After practicing the technique multiple times, you enter the associative stage. Now, you don't have to think as much about where your hands belong. Instead, your attention shifts toward refining the technique. You begin noticing whether your body mechanics feel efficient. You recognize when your stabilization isn't quite right. You start adjusting the amount and direction of force, and your instructor gives you more specific feedback like move your contacts slightly more anterior or use your legs instead of your arms. Your your errors become less frequent and your movements become smoother and more consistent. Eventually, with enough deliberate practice, you reach the autonomous stage. At this point, the basic mechanics of the technique require very little conscious thought. Instead of thinking about your own hands, you're thinking about the patient. Is the patient relaxing? Am I targeting the correct spinal level? Do I need to modify my technique because of their body size or irritability? Your attention shifts from performing the movement to making clinical decisions. That's what expertise looks like. The interesting thing is that this is exactly how our patients learn movement. Whether someone is learning a lumbar gapping mobilization or relearning how to activate their quadriceps after ACL reconstruction, the nervous system progresses through the same stages. Early on, they need more guidance and feedback. As they improve, we gradually reduce that feedback until the movement becomes automatic. Understanding these stages doesn't just make you a better learner, it makes you a better teacher. As physical therapists, our job is to recognize where our patients are in the learning process and provide just enough feedback to help them progress to the next stage. Now think about how your role as the therapist changes across these stages. During the cognitive stage, you'll often provide more demonstrations, more verbal instruction, and more frequent biofeedback because patients are still trying to understand the movement. As they become more proficient, your role begins to shift. Instead of constantly correcting every movement, you allow them to solve more of the movement problem independently. By the autonomous stage, your feedback becomes much less frequent. In fact, providing too much feedback at this point may actually interfere with learning because the patient becomes dependent on your input instead of developing their own internal awareness. A good therapist isn't someone who gives the most feedback. A good therapist knows when to stop giving feedback. Not all feedback comes from the therapist. Intrinsic feedback is the information patients naturally receive from their own sensory systems. As they move, they feel joint position through proprioceptors. They experience muscle tension. They see where their limbs are in space. They hear their feet contacting the ground. They may even receive tactile information from tape, clothing, or the treatment surface. This information exists whether we're present or not. Ultimately, intrinsic feedback is what patients will rely on once they leave our clinic. That's why our goal isn't simply to provide external information forever. Our goal is to help patients become better at interpreting their own intrinsic feedback. Extrinsic feedback, also called augmented feedback, comes from an outside source. That source might be the therapist, a mirror, an EMG display, a pressure biofeedback cuff, a force plate, or a laser pointer. There are two major categories of augmented feedback. The first is knowledge of performance, or KP. This focuses on how the movement was performed. For example, I might tell a patient, your knee drifted inward during your squat, or you maintained excellent trunk control during that lift. The second is knowledge of results, or KR. This focuses on the outcome. Examples include you held the contraction for 10 seconds, or you reached the target pressure on the biofeedback cuff. Both types of feedback are valuable, but they answer different questions. Knowledge of performance tells the patient how they moved. Knowledge of results tells them what happened. One of the most important decisions you'll make as a clinician isn't simply what feedback to provide, it's how often to provide it. Research consistently shows that more feedback isn't always better. Early in learning, frequent feedback can improve performance because patients need guidance. However, if we continue providing feedback after every repetition, patients often become dependent on that external information. Instead of learning to interpret their own body signals, they wait for the therapist to tell them whether they were correct. That's why motor learning research has shifted toward reducing feedback as learning progresses. Think of biofeedback like training wheels on a bicycle. They're incredibly useful early on, but eventually they have to come off. Constant feedback means the patient receives information after every single repetition. This often produces rapid improvements during the treatment session because every mistake is immediately corrected. The problem is that excellent performance during practice doesn't necessarily mean excellent learning. Patients may become very good at performing only when the therapist or biofeedback device is constantly guiding them. As soon as that feedback disappears, performance often declines. Constant feedback is usually most appropriate early in the cognitive stage when patients are first learning a completely new movement. Intermittent feedback is provided less frequently. Instead of correcting every repetition, we intentionally allow patients to perform several repetitions independently before providing additional guidance. Initially, this often results in slightly more errors and may even appear less successful than constant feedback. However, over time, patients become better at evaluating their own performance because they aren't relying entirely on the therapist. Although learning may appear slower, retention and long-term performance are often significantly better. This is one of those situations where we have to distinguish between short-term performance and long-term learning. With bandwidth feedback, we establish an acceptable range of performance before beginning the task. If the patient's movement falls within that acceptable range, we say nothing. Only when their performance falls outside that bandwidth do we provide corrective feedback. Imagine a patient performing a squat. If their knee position remains within an acceptable range, we allow them to continue without interruption. If the knee collapses dramatically into valgus, then we step in and provide instruction. This approach encourages patients to solve small movement errors independently while still preventing major mistakes from becoming habitual. It also naturally reduces the amount of feedback over time as the patient's movement improves. One of my favorite ways to understand bandwidth feedback is by thinking about the classic game Operation. If you've ever played the game, your goal is to remove the plastic body parts without touching the metal edges of the opening. As long as your tweezers stay within the opening, the game says nothing. You don't receive any feedback at all. But the moment you touch the metal edge, the buzzer sounds and the patient's nose lights up. Suddenly, you know you've made an error. That's bandwidth feedback. The game doesn't tell you every time you're doing something correctly. It only provides feedback when your performance falls outside an acceptable range. In other words, there's a window of success. As long as your movements stay within that window, you're allowed to continue without interruption. Only when you exceed the boundaries does the game step in and tell you that you've made a mistake. This is exactly how we often want to teach movement in rehabilitation. Summary feedback takes yet another approach. Instead of providing feedback after each repetition, we wait until the patient completes several repetitions before discussing their overall performance. For example, I might ask a patient to perform 5 squats. Rather than interrupting each repetition, I watch the entire set and then summarize what I observed. This encourages the patient to focus on performing the movement instead of constantly waiting for my comments. Summary feedback also promotes reflection. Before I provide my observations, I might ask, how did those repetitions feel? Or did you notice any differences between the first and last squat? Those questions encourage patients to begin evaluating their own movement, which is exactly what we want. Now, let's discuss something that seems simple but can dramatically influence how well patients learn movement: the words we choose as therapists. We generally divide our instructions into two broad categories: internal focus and external focus. Internal focus directs the patient's attention toward their own body or muscles. External focus directs their attention toward the intended outcome of the movement or something in the environment. Neither approach is always right or wrong, but current motor learning research has shown that, particularly once patients understand the basic movement, external focus often produces more efficient movement, better retention, and greater transfer to functional activities. As you'll see over the next few slides, simply changing our wording can completely change how patients perform a task. Let's define these a little more clearly. An internal focus cue directs attention to a body part or muscle. For example, tighten your quadriceps, keep your knee over your second toe, contract your gluteus medius. These cues encourage the patient to consciously control individual body segments. An external focus cue, on the other hand, directs attention toward the outcome. Examples include push the floor away, keep the laser inside the circle, move the pressure gauge into the green zone. Notice that the patient is no longer thinking directly about muscles, they're thinking about accomplishing a task. That's often how movement occurs naturally. Let's look at these soccer examples. Notice that every instruction focuses on what should happen to the ball rather than what should happen to the leg. Kick underneath the ball. Stroke the ball toward your target. Create a pendulum-like swing. The athlete isn't consciously thinking about knee extension angles or ankle plantar flexion. Instead, they're focused on the desired outcome. The nervous system is remarkably good at organizing movement when we give it an external objective. This is one reason why many elite coaches naturally use external cues without necessarily realizing they're applying motor learning principles. Now, compare those instructions with these. Position your foot below the ball, lock your ankle, straighten your knee, swing your leg farther. These cues direct attention toward individual body segments. Internal cues certainly have a place, particularly early in learning or when trying to correct a very specific movement error. However, relying exclusively on internal cues can sometimes interfere with automatic movement because patients begin consciously controlling motions that normally occur without much thought. As clinicians, we should think carefully about which type of cue is most appropriate for the patient's stage of learning. Now let's shift from feedback to practice. Blocked practice means repeating the same skill over and over before moving to something new. Imagine teaching a patient to perform 10 straight sit-to-stands, followed by 10 more, and then another 10. Or imagine repeatedly practicing the same lumbar stabilization exercise for an entire session. Blocked practice usually produces rapid improvements during treatment because repetition reduces variability. Patients often feel successful very quickly. However, there's a trade-off. Although blocked practice improves short-term performance, it doesn't always produce the strongest long-term retention or adaptability. Random practice mixes different tasks together. Instead of performing 10 identical repetitions, the patient alternates between several different activities. For example, one squat, one step down, one balance task, then repeat. This requires the nervous system to continually solve new movement problems rather than simply repeating the same motor program. Learning often feels slower, and patients may make more mistakes initially. However, because they're constantly reconstructing the movement solution, retention and transfer to real-life situations are often significantly better. Think about sports. Athletes rarely perform the exact same movement repeatedly in competition. Rehabilitation should eventually resemble that same variability. These references represent many of the foundational papers that have shaped our current understanding of biofeedback and motor learning. Although the technology continues to evolve, the fundamental principles remain remarkably consistent. Before we head into lab, I'd like you to remember just 4 ideas. First, biofeedback is a teaching tool, not a treatment. Second, our goal is long-term motor learning, not simply good performance during today's treatment session. Third, every biofeedback device should eventually become unnecessary. If a patient always needs the machine, we've only created dependence, not learning. Finally, technology should support your clinical reasoning. It should never replace it. As you rotate through today's lab stations using the pressure biofeedback cuff, handheld EMG unit, and laser biofeedback, I want you to think beyond operating the equipment. Ask yourself, what movement problem am I trying to solve? What information is this device providing? How will I progress this patient?